All right. Well, thanks everyone for joining us today for a very special Renal Grand Rounds, the first one in the year. I just want to make a few comments before I go on to the introduction. First, you can see the schedule for our Renal Grand Rounds under our division events. It's also on Planet Purple. And Marissa, who organizes the seminars, sends out weekly emails and also puts the announcement on Twitter. So if you want to join us, you're welcome to do so. And on your way out, be sure to thank Marissa for doing all the hard work of bringing this all together, making sure the speakers get here, and making sure you all have food. And thank you for coming. I think we're also on Zoom. Is that right? Did that get set up? Yeah. So thank you for people who are on Zoom and the people who are here in person. So we'll go ahead and get started. And we have a special speaker today, essentially because there's a hypertension meeting in Chicago. So we're very lucky to host Dr. Paul Drawz, who'll speak to us on hypertension and chronic kidney disease, important topics for nephrology, but also cardiology and primary care. A little bit about Paul, and we learned more about him yesterday at dinner, but he grew up in Minnesota and then trained on the East Coast, Amherst College, sociology major. And then after that, he got his MD from University of Minnesota and completed his residency training chief residency training and nephrology fellowship training at Case Western Reserve University. And we know that's a very strong place because we have graduates from that residency program among our faculty, and we've also had fellows from that institution. So Paul and I actually first met when we were both starting out as junior faculty. I think we met at the American Society of Nephrology meeting. We were just funded to do work in the CRIC study with a Career Development Award. And since then, he's just been a pleasant person to know about, to see how his career has evolved. And I got a chance to also meet him through American Journal of Kidney Diseases, where he was the reviewer who received the Reviewer Hall of Fame honor. And just a few other honors and service commitments to highlight, of which there are many. As I mentioned, he's an expert in hypertension, involved in hypertension groups, including he is chair American AHA Hypertension Scientific and Clinical Education Lifelong Learning Committee. He's also a member of the National Kidney Foundation Program Committee and a standing member of an NIH study section. And he was previously a senior editor of Journal of American Society of Hypertension. But I think more importantly is his service locally is worth pointing out. So he served as an interim division chief for 18 months. That's a hard job. And he also is very heavily involved in the fellowship education. I believe I saw that he actually received a number of awards, something like top 20% fellow evaluation. Maybe we should think about incorporating that award here, Jay. What do you think? Anyway, without further ado, thank you very much, Paul. We're really delighted to have you here.
Thank you for that very kind introduction, and I'm honored to be here today. So most of the work that I do utilizes electronic health record data. So when I think about my expertise, it's not necessarily in hypertension or acute kidney injury. It's the use of retrospective data for research, public health surveillance. And I'm going to present a couple of case studies on how I've used EHR data, and then talk a little bit about the strengths and the weaknesses of EHR data for these purposes, to hopefully spark in you an interest in utilizing electronic health record data for clinical research. So some of this work was funded by my first R01 from NHLBI. This was the SPRINT EHR ancillary study. And then the second part was funded by the Minnesota Department of Health and local public health agencies, where we're collaborating on community health assessments. As I said, I'm going to briefly talk about results from the SPRINT electronic health record ancillary study. I'm going to talk about the estimates that we often cite for CKD prevalence here in the United States using data from Burfus and NHANES. Talk about the community health assessment program that we're doing as part of the Minnesota EHR consortium. Show you some prevalence estimates using EHR data from the 11 health systems that are part of that consortium. And then I didn't test it, but if we have internet connection, I'll show you our live dashboard that has up to 15 chronic conditions prevalence across the state of Minnesota. So as many of you here in nephrology are aware as hypertension specialists, SPRINT was a randomized controlled open-labeled trial conducted at 102 clinical sites across the country, and patients were randomized to a blood pressure target of less than 120 compared to less than 140. The intensive blood pressure target was associated with a reduction in cardiovascular disease and all-cause mortality, 25% reduction in both. The absolute risk reduction was only about 1%, so there's some controversy as to what the blood pressure target should be. But needless to say, it's highly unlikely that this study will be replicated. It was about $110 to $150 million to determine whether or not less than 120 versus less than 140 should be our target. What we don't know is how blood pressures in routine clinic practice compared to blood pressures obtained using a standard protocol in SPRINT. So in SPRINT, the patients came in, 5 minutes rest, arms supported at heart level, 3 readings were taken, and the average of those readings was used for guiding hypertension management. I imagine in your clinic here that bears no resemblance to how blood pressure is measured. The patients probably come in, they don't rest for 5 minutes, you might get 1 reading, and they probably don't have their arms supported at heart level. They might not even be sitting with their back supported. And so our aim was to evaluate the concordance between outpatient blood pressure measured in routine clinic practice compared to blood pressure measured using recommended techniques at each of the SPRINT visits. So we obtained participant-level EHR data. All labs and vitals were obtained from 39 SPRINT clinic sites. And it's a little bit of a brag because 25 of those were VA sites, so all of the data from 25 sites came from one source. And we merged this EHR data with trial data. Outpatient and inpatient dates were defined using SPRINT hospitalization and ER visits from the adverse event data. And the mean difference in systolic blood pressure between group and between source was estimated using linear mixed models. So there were 9,361 individuals randomized in SPRINT, approximately 4,700 in each arm. Again, we didn't recruit all of the sites. We only recruited sites that had a large number of participants enrolled and sites where the primary enrollment was through the healthcare system. So an example of a site we didn't recruit was Colorado. They recruited a lot of participants, but they used radio, television, and other advertisement to recruit individuals. So we wouldn't have EHR data necessarily from them because they were recruited from across the community. And so in the end, we ended up with 1,500 patients with EHR data in each of the arms. Baseline characteristics of those 3,000 patients are shown here. And for most intents and purposes, this subpopulation is very similar to the overall population from the SPRINT trial, other than because many of these sites are from the VA, only about 20% of these individuals were female. And shown here is the results comparing the standard blood pressure arm in blue, and the solid lines are from the SPRINT trial, and the intensive treatment arm is in red. Again, this SPRINT blood pressures are the solid line, and you can see that there's an approximately 5 millimeter of mercury difference in the standard arm between electronic health record blood pressures and a 7 millimeter mercury difference in the intensive arm, with the electronic health record blood pressures on average being higher throughout the entire study. And so you might say now, well, we've got a solution. We can just measure blood pressure poorly, and we'll subtract 5 to 10 millimeters of mercury from that blood pressure, and we'll have a standard blood pressure. Well, it turns out that that blood pressure difference is not consistent across individuals. And so here's a Bland-Altman plot of intensive treatment arm on the left in red, standard treatment arm on the right. And each dot represents a participant. The size of the dots correlates with the number of outpatient blood pressures that we had. And while on average there's a 5 to 7 millimeter of mercury difference, you can see that a significant number of individuals, especially in the standard treatment arm, their trial blood pressures were actually higher than their electronic health record blood pressures. So the solution isn't to just measure blood pressure poorly and then subtract this correction factor. We need to measure blood pressure accurately. Hypertension is the #1 chronic disease risk factor in the world. We owe it to our patients. And frankly, it can actually speed up your work as clinicians. If you know that your rooming staff is getting an accurate blood pressure, you don't have to ask them to repeat it. So in my clinic, when I had clinic, I would say the only time I wanted to repeat a blood pressure was if I was thinking of sending the patient to the emergency room. It was either very low, very high, or they were symptomatic. And this is just to point out that if we looked at blood pressure difference at 6 and 18 months, there's a big difference in blood pressure between the sprint blood pressures at month 6 and month 18. And this highlights that blood pressure is variable. We shouldn't treat or diagnose hypertension on the basis of one reading in clinic. We need to have multiple readings to make that diagnosis. And we shouldn't change treatment based on just one reading. There's a home blood pressure monitoring protocol here. I think that's a great way to get multiple readings over time, and that can account for some of this variability that we're seeing. So we also, in the SPRINT ancillary study, looked at long-term follow-up. So SPRINT, 25% reduction in all-cause mortality, 25% reduction in cardiovascular disease. The study was stopped early with 3.3 years of follow-up. And the effect on long-term kidney function outcomes is unknown. And so we use this electronic health record data to evaluate the effect of intensive blood pressure lowering on long-term kidney outcomes using these outpatient measures. And then we evaluated the concordance between the estimation of GFR decline using SPRINT versus routine outpatient values during the conduct of the trial. And because I want to get to some of the others, I'm going to rush a little bit through these findings. But needless to say, so here we have during the intervention phase, so this is both SPRINT and EHR blood pressures during the intervention and the observational phase. We can see that there was an acute decline, and this acute decline is a little bit in quotes because the scale here goes from 60 to 75. So GFR went down by about 3 or 4 units with intensive blood pressure lowering in the intensive arm, and then the slope of decline in long-term follow-up was similar when we used electronic health record data. And so this was an R01, about $2 million total, a drop in the bucket compared to the $110, $150 million, and we can get an answer to what was the long-term outcome in renal function in SPRINT. We've since linked SPRINT data with USRDS data to look at end-stage kidney disease and transplant, and it turns out this was a very low-risk population for kidney outcomes. Similar analysis, so here we're looking at amongst those without CKD at baseline on the left, those with CKD on the right. In long-term follow-up, this is EHR data only. The hazard ratios for each of the periods are shown here on the right. Intensive blood pressure lowering in those without CKD at baseline was associated with a 90% increased risk for a 50% decline in GFR. And this was seen in both during the intervention period in the Sprint labs and in the electronic health record labs. And then amongst those with CKD at baseline, a non-significant increased risk for progression of CKD, and similar findings in both the Sprint labs and the EHR labs. So if we then focus on EFR decline comparing Sprint and EHR during the intervention phase, we see a similar slope of decline using EHR labs as we do using Sprint labs. And for those of you that studied the physiology of GFR and fasting, you may recognize this pattern where you see this sort of sawtooth pattern where GFR is determined in part by your fasting state. And so that's why you see this fluctuating GFR in the Sprint visits, because not all of them, it was about every other visit was fasting. And so that's why you see that fluctuation, whereas in the EHR, people at random were fasting. And so that's a little bit more of a smooth line. So in conclusion from this Sprint ancillary study, intensive blood pressure treatment increased risk for renal events during the intensive treatment phase, but not during the post-trial observation follow-up. Modest differences in eGFR decline, total slope and event rates when assessed using Sprint or EHR creatinine values. And the conclusion that I take away from this is that we can use outpatient EHR creatinine measurements to substitute for study protocol-based lab values to reduce cost and participant burden in pragmatic randomized trials. So that's one example of using electronic health record data, not typically how we think about doing it. Usually we think about electronic health record data, retrospective study, you make an observation in the clinic or the hospital, and you ask the question of the EHR data at one site. There we linked the EHR data with a randomized controlled trial to answer very specific questions. I'm now going to talk about chronic kidney disease, where we get our estimates for prevalence now that you'll see cited in much of the literature, talk a little bit about what the weaknesses of those estimates are, and then talk about how we can use EHR data to estimate disease prevalence and incidence in the state of Minnesota with the consortium that I'll tell you about. So BRFIS is the Behavioral Risk Factor Surveillance System. And the question that they ask is, has anyone ever told you that you have kidney disease? And for those of you that see patients who have kidney disease, even those with moderate to severe kidney disease might answer no to this question, right? They've got diabetes, hypertension, cardiovascular disease, they had a heart attack. They don't necessarily recall that someone told them you have chronic kidney disease. And so these estimates are quite low. So in Minnesota, the estimate is 2.8%, and I just showed Michigan, Mississippi, and Missouri here as well. In CDC places, so this is a webpage that the CDC hosts, you can drill down to your state, and you can look at county level. So this is county level data. These are estimates of county level prevalence of CKD based on that one question: have you ever been told that you have chronic kidney disease? And they even provide estimates at the census tract level. So these are what we call the Twin Cities. Those of you from the Midwest know what I'm talking about. I can't really give this talk somewhere and call it the Twin Cities outside the Midwest. Minneapolis, St. Paul. And supposedly CDC is estimating the chronic kidney disease prevalence at the census tract level based on that one question. So a little bit more about BRFIS. They conduct 400,000 interviews per year. If you do the math, there's 73,000 census tracts in the United States. So that's about 5 to 6 interviews per census tract per year. And for those of you that are not familiar with census tracts, they're designed to be a relatively homogeneous community, so for those that do research using EHR data, you might use a zip code to define neighborhood level characteristics, but zip codes are designed to deliver the mail. And so they might include neighborhoods that are well off and neighborhoods that have many needs, whereas census tracts are designed to be more homogeneous and so and to have a uniform size. as far as population is concerned. So on average, census tracts have somewhere between 4,000 and 8,000 individuals. So based on less than a 0.1%, CDC is estimating CKD prevalence in these census tracts. And they're doing that because they have 400,000 interviews, and they use a model that assigns the census tract population distribution, age, sex, race, and then the known distribution of CKD within each of those categories to estimate the CKD prevalence within each census tract. So the other main source of an estimate for national prevalence of chronic kidney disease comes from NHANES. It's a nationally representative survey of non-institutionalized U.S. civilian residents, and a subset attend a mobile exam center that has labs. And so a serum creatinine and urine albumin to creatinine ratio are obtained, which is how we define CKD overall typically, and then how it's used to define CKD in NHANES, so not based on a survey. And this paper comes from Dan Murphy, who's junior faculty at the University of Minnesota. This is from when he was at UCSF, looking at trends in prevalence of chronic kidney disease in the United States. And I'm just going to show the estimates that they reported for 2011 to 2012. They defined CKD using just an eGFR, 15 to 59, and overall, about 7% of individuals had chronic kidney disease. Obviously higher amongst older individuals and higher amongst those with diabetes. If you define CKD as a GFR 15 to 59 or a UACR of greater than 30, 14% of individuals had chronic kidney disease. So this is much higher than the Burfess estimate of 3%. But NHANES has a few weaknesses when we think about chronic kidney disease. In this 5-year period, this is from a different paper, only 80 individuals had a GFR less than 29. So our estimate of the prevalence of CKD, severe CKD from NHANES is very limited. And then amongst those with a GFR less than 30, the breakdown by albuminuria is shown below. So 29 individuals with macroalbuminuria, 22 with microalbuminuria. And so our current estimates of CKD prevalence, Burfess is based on one question. It requires patient knowledge of CKD. And it has, while there's 400,000 individuals, they claim to estimate the prevalence at the census tract level, and they're probably only interviewing 3 to 10 individuals every year within that census tract. NHANES is lab-based, but it's a one-time measurement. And so when we think about chronic kidney disease, that's a GFR decline or urinalysis abnormalities greater than 90 days. They only have one measurement. So this is really what is the prevalence of reduced kidney function or proteinuria at a single measurement. And again, the small sample size, especially amongst those with severe CKD, limits the ability to extrapolate this to the general population. Other examples of CKD prevalence estimates come from claims data, so the Medicare claims. As you may be familiar, the sensitivity of CKD diagnosis in claims data is very low. And so it's likely that's a gross underestimate. And then the VA data is a somewhat biased sample, obviously 8 to 9 million individuals, predominantly male, but they do have lab data, and so that's one way of estimating CKD prevalence. So moving on to the community health assessments that we're doing as part of the Minnesota EHR Consortium. So back in 2019, a colleague and I organized a group of individuals from health systems across the state. People like myself had access to electronic health record data, were interested in doing clinical research, interested in chronic kidney disease, hypertension, diabetes, and we came together Friday the 13th of March, 2020, and there was general consensus that yes, we could collaborate. We would use a distributed model. The data would all stay at each of the health systems, and that we would work to do research in these sort of chronic conditions. 2 weeks later, Tyler Winkleman from Hennepin Healthcare emailed that in New York City they were using electronic health record data to do COVID syndromic surveillance, and over the past 4 years now, we've done almost nothing but COVID syndromic surveillance and COVID vaccine monitoring. But it has been the curse of COVID, obviously, for the population, but we also got pulled in. None of us were infectious disease doctors, but in many ways, this moved us further along than we ever would have if we were talking about diabetes or chronic kidney disease. We have a data use agreement. We have executive committee. We've got a governance board. All of this is in place because of the urgency of informing the public health response to COVID. And now we're able to do some of this work on chronic kidney disease and diabetes that I'm not sure we'd ever be doing if it hadn't been for that. So HTAC, or the Health Trends Across Communities in Minnesota, is a unique data collaboration of health systems, local and state public health and health plans. It's led by the Minnesota EHR Consortium and other agencies, and our goal is to provide accessible, timely, and detailed community health reports using summary electronic health record data. So what was driving this need? So the data to identify and act on place-based risks are lacking. So place-based risk is in the community. Who in the South Loop, who here in Chicago has hypertension, diabetes? What communities should we be targeting as Northwestern medicine to better take care of and improve the health of our population? So health systems, health plans are required to do community health assessments. And they do these every 3 years. And in the past, this has involved surveying patients, surveying the community, so very labor intensive. And after the work that we'd done with MDH, we were approached and asked if we could participate in these community health assessments using electronic health record data. We're not entirely replacing some of those surveys. We're not entirely replacing the full community health assessment apparatus, but we're informing it with our data. And so individuals' ability to be healthy is impacted by many conditions, obviously location. So people define places and places define people. And so knowing where someone is from, knowing what census tract they come from, can tell you a lot about the challenges that they face, the opportunities that they have, their likelihood of having chronic conditions. There are a number of communities in crisis for reasons other than chronic kidney disease, but chronic kidney disease could be added to this. And centralized approaches have often failed or been slow. And so when we first started going out to organizations in 2019, over and over again we heard, the University of Minnesota has tried this before. All you ever wanted was us to send you our data, and then you were going to do research with us and thank us in the acknowledgement section. And so, a lot of this was driven by a collaboration and identifying individuals at these health systems that wanted to be a part of this, that wanted to do research with this data, that wanted to be a part of this public health surveillance apparatus. And so having this distributed data network, and I'll say a little bit about what that means, was key to this success. We're never going to get all of these 11 health systems to just send their data to one central location. So EHR data offers several advantages. It's timely, it's granular. For this project and all of the work that we do, we center our understanding on needs of vulnerable populations. It was a public-private collaboration to meet data and analytic needs of multiple pressing public health crises. And then the EHR data can allow these community health assessments to be timely, tailored to the community, and we would argue highly accurate. So the key partners here were the Center for Community Health, Hennepin County Public Health, and then the EHR Consortium, which I've been a part of. So our mission is to improve health by informing policy and practice through data-driven collaboration among members of Minnesota's healthcare community. We prioritize privacy through a distributed data model. None of the data ever leaves the health system's data server. We send code out, they run it, we get the results from, say, a model back with beta coefficients or tables, summary data. And sometimes these summary data tables can be thousands of rows long and multiple rows wide because we're getting counts by age, sex, census tract. There's 1,800 census tracts in the state of Minnesota, so it's 300,000 rows long. And so we're not getting individual level data, but we're getting very granular counts. Voluntary collaboration, we have governance, as I mentioned, and we're adaptable and nimble. And an example of this from the last month, I don't know, we're not in an infectious disease conference here, but some of you may have read that there is an outbreak of CMV. And there was a report out of Europe, and there's been now reports here. And in the last 3 weeks, we have identified that this is also happening in Minnesota. The test positivity across our 11 health systems has gone from a baseline of 5% to 15%. And we're able to do that because of the work that has gone into building this collaboration. So the 11 health systems range from Mayo Clinic in the south, Sanford and Essentia in the north, CentraCare is in St. Cloud, and then all of the major health systems in the Twin Cities also participate. So as I mentioned, we have an 11-system data use agreement. Each project includes an appendix to this data use agreement. We have administrative and technical cores, and we have a deduplication process to avoid double counting. So invariably, patients don't just go to one health system. When we're reporting on, say, the number of individuals with chronic kidney disease, we don't want to report that there's 3 times as many patients with chronic kidney disease, because chronic kidney disease patients are more likely to go to multiple health systems. And so each of the health systems sends a de-identified hashed list of their patients. We use the same hashing algorithm at each of the sites. If the hashes match, we assume it's the same individual, and then we assign health systems to report on an individual based on the number of blood pressures in the last 36 months, number of blood pressures in the last 12 months, and some other information, so that we're hopefully assigning patients to the health system that they have seen most frequently in the last few years. So we utilize electronic health record data, census data at the census tract level, including social vulnerability index, income, and rurality. We have data from the Department of Health's immunization registry on vaccines. We also have linked this with information on vulnerable population, including the state homeless shelter data, incarceration data. We have information on mortality from the state, and we also monthly get a list of individuals who are enrolled in Medicaid. So schematically, and actually further to the left here, you have to write the code, develop the code sets, but each health system is sent the code and the code sets for whatever analysis that we're doing. They run them internally, and then they send the summary data to a box, and those are then aggregated, and we only report on the summary. The summary is one of the things that keeps us together, is that we don't report on individual health system metrics in our reports. This is very busy. I won't go into the detail, but needless to say, the sites send us their patient roster. We get external data from our various sources. These are merged together, and each health system receives back a file that only includes information about their patients. Were they on Medicaid that month, their vaccine data, their homelessness and incarceration information, and then a deduplication variable as to whether or not they should report on that individual in certain analyses. The code is run at each site and then summarized with whatever the coordinating center is for each project. Just a couple of words about OMOP. For those of you who have used electronic health record data, it's incredibly messy. You all have Epic here. You may have heard about Clarity. Clarity is the database that sits behind Epic. There are hundreds, if not 1,000 tables in Clarity. And a Clarity database here versus a Clarity database at the University of Minnesota might be completely different. Might have different table names, different variable names, might have different formats. And so OMOP is one of a few common data models. I think at this point it's probably the most popular common data model that takes all of that data and puts it into, and we've only really implemented about 12 of these tables, but same table name, same format, same variable name, so that one set of code that we write at the University of Minnesota can be sent out and run at all of the 11 health systems with only some minor modifications. Okay, so now that was NHANES-Burfess, background on the EHR consortium. Now I'm going to come back to chronic kidney disease. So how did we define chronic kidney disease? You might think, well, it's easy. It's a GFR less than 60 separated by 90 days, or UACR greater than 30 separated by 90 days. But this is EHR data, so there's missingness. You have people who've only had one lab value. And so I'm going to present what we did for our first iteration, and then I consulted with Kirsten Johansson and others at USRDS and other nephrologists, and we're going to move to a different definition, which is only looking at outpatient values and only looking at the most recent value. We're not necessarily going to claim in this future iteration that people have chronic kidney disease. We're going to say that at their last check, they had reduced kidney function or they had proteinuria. And the reason we did that is when we ran this model, we looked at all different kinds of definitions, and only about half of the individuals that had a GFR less than 60 had a prior GFR less than 60 more than 90 days prior. So we don't want to underestimate CKD just because we don't have lab values more than 90 days old. So that's where we're going. Now back to what I'm going to show you now. So we're looking at only individuals who've been seen in the last 3 years, and as of December 31st of 2023, we did not have evidence of a death record. And so this is as of December 31st, 2023, what's the prevalence of chronic kidney disease in those who've been seen at one of these health systems. The numerator, hypertension, diabetes, and the others are defined by a diagnosis code in the last 5 years. But fortunately for us, CKD is defined by lab abnormalities. And so we have almost the gold standard definition of the condition in the electronic health record. And so we use GFR less than 60 with here a GFR less than 60 at least 90 days prior, or UACR. I'd love to use urinalyses for this, but across 11 health systems, what is proteinuria in a UA? Is it 30 plus? Is it 2 plus? Is it present? It's very, UA values at your institution, you know exactly what they mean, but from 11 different health systems, it's hard to determine what a urinalysis albumin result is. So very busy slide, but the point here is amongst those over the age of 18, we have nearly 4 million patients who've been seen in the last 3 years. 900,000 had a diagnosis of hypertension, 350,000 have diabetes, and 221,000 have chronic kidney disease. And of these 3.9, 2.3 million of them had had GFR measured ever at the health system that they were assigned to. So zooming in a little bit on this and changing from the numbers to percentages, 6% of the population had chronic kidney disease, and overall 60%, as I said, had a GFR measured. This varies depending on the population we look at. Obviously, younger individuals, much lower prevalence of CKD and less likely to have GFR measured. Older individuals, 90% of those over 85 have a GFR in one of our health systems, and a third of them have CKD as we've defined it here. If we look by race and ethnicity, not much. So these are raw numbers. When we age and sex adjust these numbers, you see some of the inequities that you might expect. So Black or African American individuals are more likely to have chronic kidney disease after age and sex adjustment, but these are the raw prevalence estimates. Looking at social vulnerability index, 5% in the least vulnerable, up to 6% in the most vulnerable have chronic kidney disease, and then not much difference by rurality. So urban, exurban being sort of suburbs, small town and rural, all in the 5 to 6% range. This is really just shown to show the counts by GFR. So when we talked about NHANES having 80 individuals with a GFR less than 30, we have 16,000 individuals with a GFR less than 30 in our data just for Minnesota alone. And looking at prevalence of by stage of CKD here, we see that while overall it was similar for those by social vulnerability index, when we look at severe CKD, those and more vulnerable have a higher prevalence. The counts are obviously low. And proteinuria, and I think this is likely driven by an increase in diabetes in those communities. So now, coming back to comparing our prevalence estimates to the CDC places estimates, and I've normalized the places estimates so that the average in the state of Minnesota is equal to the average that we got from the EHR consortium, so that the colors line up. Otherwise, the places estimates would all be very low. And you can see that the places estimate for CKD prevalence doesn't vary much at all. And I will point out the gray boxes here are because the CDC estimate is based on 2010 census tracts. They haven't updated to the 2020 census tracts, whereas we have ours in the 2020 census tract. And so we see much more variation across communities in our data compared to what the estimates are from CDC places. And then this is just comparing social vulnerability index, least vulnerable in green, most vulnerable in red. And the number of dots are, I divided the sample up into 10 different groups. So these are jackknife estimates, and these are adjusted for age, sex, and race. And so we see more vulnerable populations have a higher prevalence of diabetes, chronic kidney disease. Interestingly, not much difference in likelihood of having their GFR assessed, but a higher prevalence of hypertension. And so now comparing the results from Burfess and NHANES, looking at various definitions. Burfess is 3%, NHANES only GFR 7%, NHANES with UACR is 14%. In our data, if we look at only GFR, it's at 4%, GFR proteinuria 7%. If we look at only amongst those who've had a GFR measured, what's the prevalence? It gets as high as 10%. And then if we remove the requirement to have had a GFR less than 60, 90 days prior, we get an estimate of about 17%. So as we think about EHR data for research, public health surveillance, some of the strengths: lower cost, we have long-term follow-up. Some of this work was done for less than an R01 budget. If you were to do something like this and go out and survey and draw labs, it'd be tens of millions, if not hundreds of millions of dollars to get these number of individuals' lab values. We have the entire record available versus when you do a prospective study, you only measure what's in the protocol. And now there is missing data, and I'll talk about that in a minute. You also have a large sample size. We have almost 6 million individuals in our data set. So these are existing EHR data, large sample size. Even in subpopulations, we have 15,000 patients with a GFR less than 30. And it's timely. So we update our data at the University of Minnesota 3 times a week. The other health systems, the least frequent is once a month. We're updating our data because we're still reporting on COVID. So what about the weaknesses? And you hear a lot about this. There's missing data. So missing data in that one health system might not necessarily know the lab values or the encounters that happened at another health system. We also have patients who only have one GFR, or we have 30% of individuals who've never had a GFR measured. Now, many of them are less than 40. They probably don't have an indication for having a GFR measured. And so the likelihood that they have CKD is lower, but we don't know. We have non-standard measurements. We talked about measurement of blood pressure. Almost certainly across all of these health systems, it's not being measured as recommended by the American Heart Association. And then you have non-standard exposure and outcome ascertainment. Tamara and I, as we were K awardees, we probably both had the fun task of reviewing hundreds of pages of documents and PDFs to determine whether or not someone had a heart attack or heart failure. And there was a 2 or 3 page form that we would fill out to say, yes, it was, maybe it was, no, it wasn't. And so there's very standard definitions of outcome ascertainment in clinical trials and observational studies. It's a lot harder to do in retrospective data. What is an admission for a heart attack? Does it require the primary ICD code to be for a heart attack, or any ICD code for a heart attack? So non-standard exposure and outcome ascertainment. And then quality of life and survey data are frequently missing. So the other considerations, though, are bias. There's obviously bias in EHR data. Who comes to your health system? Who seeks health care? Certain populations are much less likely to be represented in EHR data, and there's biases. And when we think about machine learning and AI, we really need to take that into account. But there's also bias in clinical trials. So I've never done this before, so we're going to try this. So how many in this room have consented to be randomized in a clinical trial that lasted more than a year? Perfect. Okay. Now, it's a very young crowd. So how many of you have been seen at what you would consider to be a major health system in the outpatient setting, in the emergency room? And it's sort of a HIPAA violation, but, right? Okay, so when we use EHR data, is it representative of the population, or is randomized, right? Every randomized trial, the control group almost invariably has a lower rate of the primary outcome than they estimated when they did their power calculations. People that get enrolled in clinical trials do better than the general population. So I would argue that there's bias in both. The bias in electronic health record data is amplified. The bias in clinical trial data is minimized. But it's sort of as far as I'm concerned, it applies to both of these data sources. So I'm going to go with the conclusions, and I've got 4 minutes. I said I'd go 50 minutes. So EHR data is a resource for clinical research, public health surveillance. This HTAC project is one of the most robust real-time cross-sector data sources in the U.S. EHR data complement but not replace traditional population health survey data. Obviously, it can't replace clinical trial data. And the dashboards for this project are available at our webpage. And let's see. Maybe I can take questions. Oh, there we go. So this dashboard went live about 3 months ago, and it includes data from all 11 health systems. If you Google Minnesota EHR Consortium, you can find it. Oh, good, it's working. So it lists the health systems that participate, some data definitions. This is the population as of 2023, 5.6 unique individuals. And for those of you unlikely familiar with the census estimates that there's about 5.6 million individuals in the state of Minnesota. We're actually going to publish a paper saying that we think that the census estimate is off. We have about 80% more elderly minorities in our data than the census estimates live in the state of Minnesota. We think that many populations are very unlikely to respond to the census. They supposedly account for that in their estimates, but it might not be sufficient adjustments. And so hypertension prevalence, now here, those of you who are familiar with estimates of hypertension prevalence are probably saying this is way too low. So this is only a diagnosis of hypertension. When we add in a blood pressure greater than 140 or 2 blood pressures greater than 140, this goes up to about 35%, and the prevalence in the elderly goes up to 70 or 80%. That is going to be our next iteration. And this CKD definition is the one that I just said, which was a GFR less than 60 plus 90 days prior. And then we can zoom in at the census tract level, and then we have prevalence estimates for our vulnerable populations, homelessness, incarceration, and then Medicaid as well. So with that, I'll take questions.